Good morning, everyone. Welcome here to our ONS meeting and our program here this morning. It's entitled Recent Advances in Cancer Care, New Paradigms, Novel Agents, and What It Means for the Oncology Nurse. And the specific topic this morning is pancreatic cancer. So thanks for getting up early, and hopefully you'll enjoy this program. We have an amazing faculty here that get to introduce. Firstly, we have Caroline Kuhlman, who's from the Tucker Gosnell program in Massachusetts General Brigham in Boston. We have Amanda Wagner, who's from the James Cancer Hospital at Ohio State University. And we have Philip, who's a GI medical oncologist in Wayne State in Detroit. And myself, my name is Eileen O'Reilly. I'm a GI medical oncologist from Memorial Sloan Kettering in New York. So these are our disclosures, Caroline Kuhlman's, Philip's disclosure, Ms. Wagner's, and mine. I have a number of disclosures there for your reference. Just to acknowledge the commercial support, it's provided from Ipsen Biopharmaceuticals and Revolution Medicines, and to thank the planners, the independent review, and no additional disclosures there. So this is an educational activity. It contains discussion of non-FDA approved use of agents and regimens, and please reference the official prescribing information for each of the approved indications. Pancreatic cancer is the topic today, and this is a very exciting time in pancreas cancer, and hopefully you get a flavor of this as we go through the talk and hear from our faculty on their experience with some of the new agents as they're emerging into the clinic. So just one last point for those who aren't in the weeds every day in terms of oncology research. The focus of this is on new therapies, how we use them, what the side effects are, what the management, what the indication for those side effects, who's the right person, when in their disease course, and why should we use that as opposed to something else. And then, again, management of side effects is critical for all of us. This is what we do every day, and maximizing cancer control, but also maximizing quality of life. And that's a critical part of oncology. And this is meant to be a very practice-focused program, so that's going to be the key topic here today. As a reminder, Kaplan-Meier curves will show a few which look at, on one axis, time, and the other, percentage of patients, and illustrate the magnitude of benefit of a given program of treatment. And we look at waterfall plots, which are the bottom curve there. Then this looks at the number of people whose cancer has responded. Everything down is good, up is not good, means the cancer is growing. And you get a sense of how well a specific therapy is working. So again, we're here today, pancreas cancer, ONS, and welcome once more, and we look forward to getting us started. So we're going to start here. This is the agenda, brief introduction. We're going to look at upfront advances in what's going on in pancreas cancer, sequencing therapy, novel agents, and then a couple of new novel devices that are in development or actually approved in this disease for your reference and use. And so with that, we're going to go ahead and get started with the clinical presentation and prognosis of pancreas cancer, and I'm delighted to turn it over to Caroline Kuhlman to kick us off here.
Thank you very much, Dr. O'Reilly. Good morning. So I'm going to start by just giving an overview to get things rolling. Much of this will be review. Pancreatic cancer by the numbers. We can see in this slide it talks about that the majority of cases present as advanced disease, and most cases, localized cases, that accounts for a smaller number. Of course, when pancreatic cancer is detected early, the survival rates are better, and we know that when it's detected later, survival rates are poor. Still, over time, what we're seeing is an improvement, some improvement in outcomes for patients with the advent of newer treatments. Overall 5-year survival for all comers and patients with localized disease, those survival rates have doubled. However, in distant disease, we can see that it's essentially unchanged. So for patients with metastatic disease, to date, that has not really improved. So pancreatic cancer accounts for about 3% of all cancers in the U.S. and about 7% of all cancer deaths. The average lifetime risk of getting pancreatic cancer is about 1 in 58 for men and about 1 in 60 for women. And again, this slide clearly shows that distant disease at presentation portends a poor survival rate. So why is pancreatic cancer so hard to treat? Well, there are probably several reasons that account for this. One has been historically the lack of targetable mutations that we've seen in other cancers. The other thing is that pancreatic cancer is hard to detect early. We don't have a screening mechanism where we can pick it up like a colonoscopy. And then finally, the microenvironment of pancreas cancer, where the pancreatic cancer grows, probably creates some challenges of the actual microenvironment, making it difficult to deliver drugs to the site. So what are the risk factors? These are really the somewhat modifiable lifestyle risk factors for developing pancreas cancer. The single biggest one is tobacco use. Cigarette smokers are far more likely to develop pancreas cancer. In fact, their risk is twice as high in smokers versus non-smokers. Obesity is a risk factor, so patients are 20% more likely to develop pancreatic cancer when they have a BMI of greater than 30. Diabetes puts people at risk for developing pancreas cancer, especially type 2 diabetes. It's hard to know if that's a cause or effect. And then conditions such as chronic pancreatitis, which can be brought on by heavy alcohol use, and that increases one's risk. Other non-modifiable risk factors for pancreas cancer are IPMNs, which are intraductal papillary mucinous neoplasms. These are benign lesions of the pancreas that are often picked up incidentally, but they do need to be followed because they increase your risk. About 2 to 9% of those IPMNs can develop into an invasive cancer. And then there are some inherited genetic syndromes, such as the breast and ovarian syndromes, the BRCA1 and 2. There is P16, which is the familial melanoma, and familial pancreatitis, Lynch syndrome, and others. Risk factors that have an unclear effect but are highly suspicious for a relationship are diet, and those are diets that are, red meat, processed foods, high-fat, sugary foods, physical inactivity, alcohol, coffee, although you'll never get a bad word about coffee from me, aspirin, H. pylori. Those are conflicting. So how do these patients generally present? Well, I put jaundice as the number one, but really the most common side effect or presenting symptom is pain. People typically present with mid-epigastric abdominal pain that gets treated for like gastritis, typically, initially. These patients can also present jaundice. Lesions in the head of the pancreas can cork off the common bile duct and cause bile to back up into the bloodstream, and patients have icteric sclera. They have dark urine, light-colored stools. These patients also have trouble, they're losing weight, they lose their appetite, they occasionally develop symptoms of gastric outlet obstruction, they're nauseated, they vomit, they can also have duodenal obstruction. Patients can present with diarrhea from pancreatic insufficiency. They may experience a worsening of their diabetes. Also, a new onset diagnosis of diabetes can be a heralding sign of pancreas cancer. And finally, blood clots. So again, these patients, a majority of which present with advanced disease, have very poor survival rates. So what can we do for these patients? So I'm going to talk about the importance of palliative care in this population. I'm going to present a case. So my patient is a 69-year-old man who presented in the typical way with abdominal pain. He was diagnosed with a pancreas cancer. This is a guy who had 2 adult children, lived on a farm in New Hampshire, and was, when he came to us, was a pretty fit guy. He was extremely active, but was really experiencing a lot of abdominal pain, had trouble moving around, wasn't able to work on his farm. He was a fit guy, so we started him on first-line FOLFIRINOX. He was really struggling when he presented. We initiated all the supportive measures we typically do, referral to social work for supportive talk therapy, but also resources, referral to nutrition, palliative care for pain management, and we engage our interventional radiology colleagues and GI colleagues to manage other issues associated with metastatic disease, like draining malignant ascites, et cetera, or biliary stent changes. I want to just talk a little bit about early involvement of palliative care. I'm going to reference a study that was done at my institution. I realize this was very old, but it is a compelling first-of-its-kind study where we randomized patients with metastatic lung cancer to receive standard management, which was just management of their symptoms with their oncologist, versus early intervention with palliative care. Those who got palliative care, early intervention, a visit with a palliative care provider in addition to their oncologist, and then they measured quality of life and depression scores at baseline and 12 weeks, and they randomized 151 patients. What's compelling about this is that, not surprisingly, the palliative care group had better depression scores and quality of life. But what was interesting is that fewer patients in the palliative care group received aggressive end-of-life care. So these patients were less likely to get third and fourth line therapy for their metastatic cancer. But despite this, their median survival in this group was longer, 11.6 months versus 8.9 months. And that was statistically significant. So subsequent studies have validated these outcomes.
So thanks so much, Caroline. We have a lot to talk about, so we're going to just get a quick take from the audience. So I'll ask Amanda. I mean, you've seen a lot of patients with this disease, and it humbles us all how sick people are. But just give us a feel for how somebody is walking in the door with pancreas cancer.
So so just thinking, looking through all of those things as far as the symptoms that patients present with, that first visit is extremely overwhelming, not only for the patient, but also for us as far as, okay, what symptoms are we dealing with right now? Like, are we treating pain? Are we treating nausea? Are we treating pancreatic insufficiency? So spending a lot of time just going over symptoms. And then you have to talk about treatment and kind of what that implies. So it definitely is a big challenge for all of us.
It's a lot. And now I'm going to ask Philip if you can comment just where you integrate supportive care. Is it at diagnosis? Is it with people with metastatic disease? What's your practice?
Well, thank you for the question, because I'm a diehard palliative care supporter. And it's a bit of I used to work somewhere, previous employment was, we called it supportive care. Now, in this hospital, we call it palliative care. And the problem is sometimes the word palliative means that if you're referring them to palliative care, the patient or the family will take they will feel that you're really planning for end stage, which is not really the case. I personally, I was in a meeting the other day. We're looking at our numbers, and there's the issue of multiple things of patients being admitted. And in my opinion, any patient to stage 4 cancer should be considered for a palliative care unless proven otherwise. Start with they need palliative care when they're newly diagnosed, because in my opinion, the new diagnosis is a trigger for you to consider. Unfortunately, a lot of places that thing may not happen for a number of reasons, and one of them is that people just don't think about it. And also there is also the issue of, is there enough staffing of palliative care people to see patients, especially when they need to be seen at a more urgent basis.
And I would just add to that aggressive palliative care is the hardest work we do, and it's as important as any chemotherapy we give to a stage 4 pancreas cancer patient. So encouraging patients it's a lot of education around saying to them, we're not giving up by referring you to palliative care. This is the toughest work we do, is to help you do well, because it can help you not only feel better, but live longer.
Yeah, thank you so much. And I think it's not to get caught in terminology here because that can have negative connotations for people, but to stress that it's an integrated approach. And as we treat the cancer, we need to support the symptoms and manage the disease-related side effects. And that's how we maximize outcomes in this disease.
Again, I want to add, when you have someone who's really followed up by palliative care and they're helping with the symptoms, it also allows the patient to stay on treatment longer because we can work around the side effects, kind of. So you have side effects and you have disease effects, right? But if you can work in tandem with the palliative care people, patients can stay longer on treatment. And I think part of the reason why the study shows better survival, like in lung cancer, is because they can even stay longer on the treatment rather than be just taken off the treatment.
Yeah, thank you. I think Caroline was going to make that point in her talk that outcomes are maximized with effective symptom management, and that's a thanks to you all in the room because what you do every day is critical to patient care and maximization of outcome. So with that, we'll kind of move now to where we are in terms of the current state of the art from pancreas cancer. And I'm just going to pick up on what Caroline introduced, that the epidemiology of this disease is changing, right? It's still a disease of an older person, average age at diagnosis being 70s, but we are seeing this little bit of a scary trend in younger people with pancreas cancer. And it's probably not a week goes by that I'm not seeing somebody, and maybe Dr. Philip too, who's under 40 with the diagnosis of this disease, and occasionally now even under 30. And that's a scary trend, and there are lots of reasons out there as to why this might be happening. This is a trend that's been observed in cancer in general, in many GI cancers, and you've all heard the story and read about colorectal cancer in particular, but we're seeing it not quite to the same degree in pancreas cancer, but evident. And everything from lifestyle, from epidemiology, to in utero exposures, to environmental considerations, to the microbiome have been implicated as possible contributing factors. So this is a large area of work to understand this, and people obviously being affected with this disease in the prime of their life is huge implications for society and obviously that person and their family very directly. So context here for treatment. This is a very typical story. This is an older gentleman. He was an electrician, so he might have had some exposures over the years. He was a former smoker and presented, as you heard a few minutes ago, with weight loss, fatigue, and pain. And this scan, so just the CAT scan here, what you're looking at is, if you can imagine, head through the screen here and feet in front of you, and you're looking at a cross-section in the abdominal cavity, and you can see there are multiple light areas there which reflect metastatic disease. This gentleman was recommended Nalirifox, and we'll hear a lot about this during the program. It's irinotecan, it's 5-FU, vitamin leucovorin, and oxaliplatin. As we always say, all our favorite drugs in GI oncology put together in a nice formulation. He had a tough time with the first cycle and experienced diarrhea and dehydration. Sodium was off, down, potassium was low, magnesium was off, all needed support and hydration. And then went on with a dose reduction, but ultimately had excellent cancer control. And you can see here, he had a very nice response, very visible radiographic regression, and marked decline in CA19-9. That's one of the biomarkers that we use to follow. It's not an absolute arbiter of what's happening, but it is helpful for patients. So with that, how do we think about selecting what's the right choice for that given person? And there's no formula here. There's a lot of things that we think about, how their functional status is, their level of health and well-being, what their comorbidities are, age, how their liver function is, and that's particularly key in pancreas cancer because people can have a lot of liver disease and they can have dysfunction that way, or they can have jaundice and biliary stents and their LFTs are improving. Patient preference, this is critical. Some of the treatments we use have infusional therapy, so people are tied up with a pack, and some induce alopecia. Almost all of our regimens have some degree of neuropathy, and for people who have skilled professional considerations and other tasks, they can be an issue. logistics, where they live in relation to their treatment center, and increasingly, and you're going to hear a lot about this in this program, that pancreas cancer is changing and in a big way because of the genomics that underpin this disease. So we have a number of combination chemotherapy regimens that are established standards, and without, again, burdening with all the details here, FOLFIRINOX, which is some similarities to NALIRIFOX, gemcitabine, nab-paclitaxel, and all of these treatment programs have been shown to shrink cancer, to control disease and extend life compared to the current prior standards. And they are used every day in the first line, second line, and various versions in the third line setting for those that are well enough to receive a third line of treatment. So this is the data that led to NALIRIFOX being FDA approved and guideline endorsed in pancreas cancer. And this was compared to, a harder reference regimen than some of the older studies. So it was compared to a doublet. So it's a triplet. If you exclude leucovorin, it's a triplet versus a doublet. And the triplet, in principle, was a win here. Survival was improved, cancer control was improved, and the ability to shrink the cancer was also controlled. And you can see how that looked graphically over time on this Kaplan-Meier plot. And that led to a shift. I think the shift is continuing to be dynamic here in terms of what's happening. So this is how we sequence pancreas cancer. Essentially, what you didn't get in the front line, you'll get in the second line in various versions and vice versa. And integrated in all of this, and I want to stress this, is genomics. So these are the data supporting second-line therapy. They're all very consistent multiplicity of regimens here. But I'm going to spend a couple of minutes on genetics. So a reminder here what germline means. Germline we inherit from our parents. We get a set of genes from our mother, a set of genes from our father. That makes us uniquely us. And that's germline. Somatic is something that's exclusively to the tumor, but we can pick up somatic variants in blood, and that's mostly what we're looking at when we do ctDNA. And these are, again, key to pancreas cancer and to essentially every disease. And in pancreas cancer, we have this kind of point-of-care testing. So at the first visit, in addition to everything else that needs to be addressed from the symptoms and the treatment plan, we want to get genetic testing underway. Germline testing, so looking for predisposition that Caroline mentioned, and for somatic results to understand how we can apply that to their treatment. So this is a big active area. So a lot of information on this slide, and really just look at the top green boxes in terms of thinking about this. So we think about KRAS, a mutated disease that's been the holy grail forever and is now targetable. We have this subset who don't have a KRAS mutation. That's a relatively small group. And then we have other groups who have mismatch repair deficiency where immunotherapy may be used, or homologous repair deficiency where things like BRCA can inform targeted treatment options like platinum drugs and PARP inhibitors. And those, that's the kind of the prototype for the biomarker selected group in pancreas cancer. Here's the germline variants that we see. These are we look for, we test for every day. They're there for your reference. And this is an example. This is a lady who's in her 60s who was diagnosed now a decade ago, right? Just reference that, a decade ago with symptomatic metastatic pancreas cancer. She'd see a CA99 of 40,000, had an amazing response to platinum treatment, and then maintained on a PARP inhibitor. And we have this dilemma. We don't know what to do. Should we stop it? Should we continue it? It's, who knows what the right answer is, but cancer control is maintained. So sum up in terms of standard therapies, this is, again, where we are today. So the epidemiology is changing, and just that younger patient population that we have to think about and have special needs. Genetic testing, right? As nursing teams, you have a collective responsibility, like all of us, to make sure that people have genetic testing. We need these results to act on it, to inform the best treatment choice for that individual. Standard of care is primarily right now cytotoxic therapy, mostly 2-drug, 3-drug combinations. special subsets that we use targeted therapy, and just a preview that RAS is coming, and we're going to spend some time talking about that as we integrate those agents into first line and to second line to start. So before we go on, I'll just ask our nursing colleagues just to comment here on how you educate patients about their treatments. They're overwhelmed, right? They have this diagnosis, they read the statistics, they're scared, they're frightened. How do you help?
So typically the first thing I will say to them is, I'm going to present you a lot of information. You're probably not going to hear half of it. So we will provide you with written information. We also do provide a separate chemotherapy teaching session if we really feel that they could benefit from that from one of our clinical pharmacists. And then additionally, I would say, please call, send me a MyChart message with any questions. And a lot of times we will then see them for that first infusion to, again, reiterate treatment, schedule, logistics, side effects, everything.
Philip, can you add from the oncology side how you weigh up these regimens? And I know you're going to speak about it a little bit as well in your talk.
In terms of
thinking about one choice versus another.
One regimen versus another, yeah. So one of the things that I look into in patients is that the reality is that any patient who comes, especially if they are relatively fit, they want the most aggressive treatment, correct? Is that something which we don't always see? We do that. And nowadays, they come to us asking about clinical trials, because years ago people didn't ask that much, but now they do, especially when new drugs coming along. And in my opinion, if someone has what you call a favorable performance status, good organ function, I will give them the opportunity of a more aggressive treatment, because I know that it may have a better chance of making them live longer in a disease that has a disease like this. However, ultimately, I also believe in decision sharing and management with the patient, so I discuss with them the pros and cons of the treatment. They have to be aware of that. So that's really my approach. But then we went back and talked about palliative care, supportive care. All these things will make a difference. If you're going to choose a treatment that may carry more side effects, it would be nice to also have that aggressive kind of approach of managing the side effects and being available for that.
Yeah, and I would just add that I completely agree. The shared decision-making, in advanced disease, it's really important to know what your patient's goals are and what their priorities are. And that can often help you shape a discussion about therapy choice.
Yeah, and thank you both for highlighting these points. And I think we want to really emphasize one, right? In oncology, we're not here to support the status quo. We're here to affect change, and that patients being part of clinical trials is how we affect change, right? And I always tell them when they're thinking and weighing up the choices, what is today's standard was yesterday's trial, and you can be part of that. And many of them recognize it isn't maybe going to be for them directly, that there may be a greater good to them, or perhaps their family's at risk of this disease and they might be impacting in the future. So clinical trials is a critical part of how we approach this disease. And as nursing colleagues who spend a lot of time talking to patients, it's supporting them, reassuring them, guiding them that this is an important consideration and choice for them. All right, so with that, I'll turn it over to Amanda, and you're going to speak to us about how we manage side effects. And again, this is a key thing for us every day, so all yours.
Right. So I'm going to spend some time comparing kind of the three regimens that we use to treat metastatic pancreas cancer, and kind of go compare and contrast their side effect profile, and then, as we discussed, kind of that shared decision making that we have with the patient as far as which regimen we're going to choose. So looking at the first regimen, which is with gemcitabine and nab-paclitaxel, kind of the way that I approached this was looking at the clinical trials in which these drugs were approved and looking at kind of the grade 3 toxicities that we saw And with this trial, so with gemcitabine and nab-paclitaxel, the way that this was dosed in the clinical trial was they received both drugs on days 1, 8, and 15 of a 28-day cycle. And the things that we saw the most was issues with myelosuppression, so specifically neutropenia. And then another big takeaway was peripheral neuropathy, so numbness and tingling in the hands and feet. We don't see a whole lot, I would say, of GI side effects with this regimen as far as nausea, vomiting, diarrhea. So, I mean, I feel like I do have a fair amount of patients that are terrified of throwing up. So presenting that kind of as one of the options for this regimen. They do, lose their hair with this, so I'm always very upfront about that. In my institution, a lot of times for patients with advanced disease that are metastatic, we will dose it differently. We'll dose it on days 1 and 15, and that kind of does help with the counts issues as well as the neuropathy. Okay, now looking at FOLFIRINOX. So this is using 5-FU, oxaliplatin, and irinotecan. In the Accord 11 trial that compared it to gemcitabine alone, they used full dose FOLFIRINOX, so that included the patients were getting a bolus of 5-FU as well as a higher dose of the irinotecan. And these patients definitely had a lot more grade 3 toxicities as far as issues with myelosuppression, neutropenia, febrile neutropenia. We saw a lot of the GI side effects as far as diarrhea, nausea, and vomiting. So in practice, most places, as far as I know, will be using modified FOLFIRINOX. So that's avoiding the bolus 5-FU, so that does help with the blood counts and can kind of help decrease the risk of mucositis. And then the irinotecan dose is dosed at 150 milligrams per meter squared as opposed to 180. And then finally we have NALIRIFOX. So this is also using oxaliplatin 5-FU, but liposomal irinotecan as compared to standard irinotecan. So in the trial in which this was approved, we also saw grade 3 toxicities from, GI side effects as far as nausea, vomiting, diarrhea, issues with the blood counts as well as far as neutropenia, some neuropathy, but the oxaliplatin dose is lower in this regimen, so we typically see that is a little bit better. So kind of the key takeaways that I kind of address with the patients. First of all, some of them are very terrified of, 5-fluorouracil is given via a portable chemo pump, and they have to get a port because we have to have a more secure IV line for them to take the chemotherapy home with them. So if that overwhelms them, then, we kind of do choose the nab-paclitaxel. But some of the kind of side effect situations we look at, if they are worried about neuropathy. So say they play an instrument, they sew, they, have to work a lot with their hands if they're, in doing, maintenance or electrical work or something. Then you may want to consider NALIRIFOX or modified FOLFIRINOX with even considering stopping the oxaliplatin early after maybe 4 to 6 months over gem-nab. If patients, as I mentioned, are really concerned about GI toxicity, so especially diarrhea, the gem-nab might be an easier choice. And then if, marrow, if their bone marrow reserve is limited, consider NALIRIFOX or modified FOLFIRINOX over gem-nab. And then in older, frail patients with a decreased performance status, we would typically tend to use gem-nab-paclitaxel in this situation and probably on a modified schedule. So we're going to now kind of move into talking about NALIRI, so that's that liposomal irinotecan, and its side effects and kind of what strategies that we use to kind of mitigate those. So kind of one of the biggest ones is going to be diarrhea. So it's important, when I'm educating patients, for them to kind of tell me, what is the timing of this? Is this during the infusion? Is this, a few days after the infusion? Is this the following week? What is their baseline? Do they have pancreatic insufficiency? Are they already having frequent bowel movement? So what is their baseline? And then things that we need to watch for are symptoms, obviously, of dehydration. So kind of ways that we can mitigate this is considering atropine during the infusion, a low-soluble diet, and then just really stressing the importance of patient education. So making sure they have that loperamide in hand. I often prescribe it for them because it's easier than getting it out of those little packets that you can get at the store. Make sure they know how to use it. They don't follow the instructions on the bottle where it says you can only take 4 in a day. No, I tell them to take 2 with that first loose bowel movement and then take 1 every 2 hours. And then call me if it's not working. Because then I'm going to potentially add a second antidiarrheal with diphenyloxylate atropine. And then if I'm concerned that they're getting dehydrated, I'm going to be bringing them into the infusion clinic, checking labs, giving hydration, to try to manage that. And then nausea and vomiting, also very important to assess kind of the timing, kind of the impact on their weight and their oral intake, and then what's their risk. So, in NALIRIFOX, there is risk of giving it, of becoming, or of having nausea and vomiting. So in our institution, we will go ahead and pre-medicate with a 5-HT3 antagonist and dexamethasone, and then consider adding something like a Prepotent if we are having issues with these patients having significant nausea and vomiting. I usually always will start with always giving them delayed dexamethasone or olanzapine for a few days after the infusion to kind of help with that delayed nausea. And then again, patient education, making sure they have those prescriptions for ondansetron, prochlorperazine, prescriptions in hand, teaching them as far as how to, schedule them, call if symptoms aren't controlled, and then again, we'll get them in if we need to, if we find that they're becoming dehydrated and unable to keep things down at home. Other side effects would be neutropenia. So obviously we're going to assess a CBC before each cycle. Kind of what are their risk factors? Are they an older adult? Have they had prior treatment with therapy that they have been neutropenic? Are we concerned about it? If they do have a UGT1A1 28 their homozygosity, which means that they aren't going to metabolize the irinotecan as well. So it's going to hang around longer and cause more side effects and increase their risk of neutropenia. So obviously if their ANC is less than 1,500, we're not going to give treatment. And then we would consider adding growth factor support if we need to. And then fatigue, as far as it causing, assess the pattern. Is it infusion? Is it cumulative? Other causes, anemia, dehydration, sleep disruption, or pain. And then obviously we're going to treat reversible causes. We add hydration as needed, encourage activity, consider physical therapy, and dose adjustments if needed. So looking at NALIRI's dosing, when we're giving it with NALIRIFOX, so in combination with oxaliplatin and 5-FU, the dose is lower at 50 milligrams per meter squared. In the second line setting, following progression on gem-based therapy, the dose is actually at 70 milligrams per meter squared in combination with 5-FU. So triplet versus double, it is lower in the NALIRIFOX. So do dose reductions kind of impact efficacy? Really, there's no convincing evidence that it does. I'm always say it's better to be in you at a lower dose than to not give it to you at all. So that's often in practice what we have to do to continue giving therapy versus early discontinuation.
Great. Well, thank you so much. And you emphasized a really, really important point, right? That I think sometimes we see some reluctance in practice is that, somebody who is not able to get treatment is sitting on the shelf because of toxicity isn't doing anybody any good. So it's much, much better to dose adjust, to get ahead of symptoms, and to maximize kind of well-being. And Philip, can you just give us a one-liner on the highlights for NALIRIFOX and FOLFIRINOX in terms of toxicity that are red flags for you?
For NALIRIFOX versus...
Not even for comparison, but just like neutropenia, diarrhea, combinations and things.
So certainly the GI toxicity is something we have to be watching for. And you have to be... when I see patients and treat them, we try to educate them very well about the side effects. That's very important. That's part of our oncology practice. At the same time, we keep a close eye on the patient. We see them a week after we start treatment because that is a really critical time when you evaluate a patient and you know how they're going to be responding to the treatment.
Great.
So close monitoring and liberal use of IV fluids if necessary, and aggressive use of the anti-diarrheal. I mean, these are the things which we focus on. And also the choice of the patients in terms of their comorbidities, age, and the UGT1A1 you mentioned. I mean, that's something we routinely, it has to be done before starting treatment. The question is if it's not homozygous, it's heterozygous, do you reduce the dose? I tend to reduce the dose also.
Great. So with that, I think we'll go on to our next part of our talks here, and I'm going to ask Dr. Philip to walk us through management of advanced disease. So, thanks, Philip.
You wanted me to give a one-liner, but it was longer than that. Yeah. So this is talking about relapsed refractory metastatic disease. I mean, you heard a very good separation of the stages we see. Caroline did a great job on that. And the message there is that most of the patients we encounter in the clinic, newly diagnosed, have advanced disease. And with that in mind, this type of cancer, we really have to have a very strong team effort to try to manage the patient. And here, you know what I'm talking about. The role of the nurses is very important. So you see the patients every day. You see patients, they come for treatment, and you know that after 3 months, 4 months, 5 months, 8 months, their disease is going to progress despite the fact that they're getting nalirifox or gemcitabine, nab-paclitaxel. So the question is, what do we do for those patients? Many years ago, we didn't have much to do because we had one line of treatment and that was it. Now, luckily, we have more than one line of treatment. We're going to end up with 2, 3, 4 lines of treatment hopefully soon. So that's really where this refractory thing is coming along. The good news is that we have more options for those patients. But those patients, you'll be seeing them very frequently. So as nurses, you have to be aware of it and know that how to really also be patient advocates. So the question was, what are the key factors that determine what we do in the selection of treatments in the refractory setting, patients who failed the previous treatment? Age is always important. You heard about the side effects, and I'm not going to really expand on that. Performance status, similarly, is very important. And then organ function. Why do we talk about organ function? Because it can be affected by the disease itself, the cancer, like spread to the liver, for example, or it could be affected by the previous line of treatment they received, the bone marrow function, the liver function, and the nervous system. We're talking about neuropathy here, which could have been a result of the frontline treatment, because both of the regimens we use in the frontline treatment do cause neuropathy. And another thing is that what we choose also depends on access to a clinical trial, which we can discuss later on. So Napoli-1 was the original trial that tested liposomal irinotecan in combination with 5-FU, and at that point of a study that was successful in terms of hitting the primary endpoint, the drug was approved by FDA. And this is just a few things for you to know which patients went into it. There were patients with favorable performance status. This is a refractory setting. Patients who had reasonable bilirubin levels. And this is the design of the trial. So it was a randomization of Naliri, and as you heard, it was 70 milligram per meter squared in that study versus 5-FU leucovorin. There was an arm which was Naliri alone, but that was not counted in the final analysis. And the primary endpoint was overall survival, and more than 400 patients went on it. This is just to give you a very quick summary of the outcome of the study that really got it FDA approval. The median overall survival was improved from 4.2 to 6.1 months, and the median progression-free survival time it takes for the disease to get worse also was doubled. So that was a positive outcome. Now, when you come to the side effects, this is a bit of a rehash of what you heard about potential side effects with this drug or this class of drugs. The GI toxicity, diarrhea, vomiting, nausea, and the general side effects like appetite depression and fatigue, and the hematological neutropenia and anemia. When I use this regimen in the refractory setting, I seldom use any growth factor support for it because I tend to maybe more reduce the dose. And how do we mitigate the side effects? Proper selection of the patients. Now, it doesn't mean that someone who is older or the performance status is borderline, you can't use the regimen, but you just have to adjust the doses according to that, and also for the liver function. And then we always do check for the DYPD germline to predict for the few side effects and the UGT1A1 as I mentioned. And the most important thing is that you have to really put the patients under close monitoring, especially in the first few weeks of the treatment. Not all patients, I start with 70 milligram per meter squared. Older patients with fair performance status of 2 or even 2.5. UGT1A1 intermediate, I also do some dose reduction and definitely for the UGT homozygous. And borderline liver function. But again, remember one thing, reduced doses are better than missed doses because reduced doses keep the patients longer on a treatment and probably help the patient live longer. That's an important point. So as you saw previously, Eileen did a good job in showing the lines of treatment. We have several lines of treatment, first line, second line, third line, and we have a drug, daraxonrasib, which she's going to explain to you how it will be getting into the second line. And this is really a good picture for you to know what happened. I mean, in the middle of 1990s, we had gemcitabine as the only drug we have. I remember being in meetings with Eileen. At that point in time, it was gemcitabine and maybe adding another drug. And look at 2006 now, how we have advanced in producing so many advances that went into treating patients. So this is really a great asset for the patients.
So thank you so much, Philip. That was great, and I love your approach of being again ahead of symptoms and side effects. Really, really, really key. And do you want to comment, Amanda, a little bit, and Caroline, just about how you think of management of diarrhea? I mean, you gave us a good overview, but what are the tips?
Yeah, the tips are to be aggressive early onset. People get very hung up on following the directions on the box. I can't tell you the number of patients who've said to me, I can't take more than this because it said so. But aggressive early management and then communication. If what you're doing at home isn't working, you have to call. Even if you've been through first line loperamide and then diphenhydroxylate atropine and it's not moving the needle, those patients need aggressive management. We do have third line agents we would use for bowel control and fourth line, and they need to be seen, hydrated, and monitored for electrolyte deficiencies.
Yeah, so hydration, and more hydration. Right? That's really helpful for patients, so thanks for bringing that up. Philip, in terms of dosing for older people, you mentioned this, that you typically don't start at the full dosing. Where do you start?
So if you're referring to the 70 milligram per meter squared, and the UGT1A1, there is no concern about that. In older patients, I will start somewhere between 40 to 50.
Yeah.
I will be maybe closer to 40 even, because of patients' tolerance.
Yeah, and I think just as nursing colleagues, not that you're necessarily focused on the dosing of what our colleagues are writing, but it's just a kind of real important point just to go gently in older people and people with comorbidities. You can always scale it up, but just start slowly is I think wise. Great. So I think with that, we're going to go to the next part. We're now moving to where the field is headed, and this part is entitled Novel Strategies, RAS Mutations in Advanced Pancreas Cancer. And I'll kick us off on this part. And I think, and hopefully you'll agree, this is a real time of change in this disease, and we're going to see some new treatments this year. So a reminder of the biology of pancreas cancer. Pancreas cancer is the disease of RAS. RAS is a gene that's switched on, it's altered, it's bad, it drives growth, it drives angiogenesis, it drives metastasis, and it's essentially ubiquitous in pancreas cancer. if compared to any other disease that we take a look at, again, this is the disease of RAS, and this has been known forever, but what has been the challenge is that there weren't good effective targets for this, not for want of trying and amazing science over the years and multiple different approaches, but in the clinic they failed. And that is the part that's kind of changing. And while we're talking today about pancreas cancer, there's potential for some of the drugs that we're going to discuss that may have wider application in many other diseases, and some of them are here for your reference. So this is what got me really excited, and this is a few years ago now. It was back in 2022 when we were starting in the first studies of the RAS inhibitors. This was a lady in her 60s. She was a human resources manager, and she came in, again, relatively sick with her disease. You can see she's got liver metastasis, a body of pancreas primary, and we routinely sequence these people from the perspective of the genetics, and she had a KRAS mutation, G12V, second most common. She went on to receive clinical trial therapy with immunotherapy and then modified FOLFIRINOX, another clinical trial with a monoclonal antibody, and then 2 standard regimens. And just to make the point that the disease control got less as she went down the treatment. And then for a fifth line, we have 1 line of treatment approved, and some people will go on to a second, but here we are, 5th line. So a highly refractory, difficult setting, rapidly rising CA19-9, pain, weight loss, just very, very uncomfortable. And went on to receive a RAS-targeted therapy, daraxonrasib, which is the drug that we'll talk about in some detail, and had this remarkable response. I mean, remarkable. She was feeling better within a few days. Her pain was improved. CA19-9 was starting to go down within a week. It just, it doesn't happen to everybody, but this happens a lot. And you can see here just this CA19-9 as her disease was accelerating and declined as her symptom improvement evolved. And then, of course, ultimately did progress. But that in the clinic, and seeing that not once, not twice, but pretty commonly for people in this setting was, a very significant light bulb for us all looking after these individuals. So this is the first set of data for this drug, daraxonrasib. What it's called is it's a multi-RAS-on tricomplex inhibitor. It's a bit of a complex name, but basically it binds a protein in the cell, cyclophilin, and sticks like a glue to RAS and kind of switches RAS and all that downstream signaling off. That's how it works. This is the waterfall plot in previously treated disease. So all those down lines are good. That's the cancer shrinking and responding. And if you look here, if we take a person who's had previous treatment, we expect, response rates 5, maybe 10%, meaning 5 to 10% of people will have tumor shrinkage. Here, it was a third of people were having tumor shrinkage. And if you look at this, and admittedly selected healthier patients who are enrolled in a trial, but the overall survival in previously treated pancreas cancer is 13 months. Dr. Philip and Caroline and myself, we showed some slides about the outcomes being less than a year, typically, in the first-line setting. So this is second-line setting, right? So these are, again, promising signals here. There are, though, some concerns, and our panel here will discuss this in a lot of detail, but I'm just going to highlight a couple of things. Rash, and this has gotten a lot of publicity in the media and social media about this. We do sometimes see some mucositis, irritation in the mouth, and diarrhea and GI toxicities, mostly lower grade, but definitely requiring attention. And we'll talk about prophylaxis in terms of the rash, treatment of the rash, using dose holds, dosing interruptions, and sometimes we need to dose modify. Rarely need to discontinue this, but this is going to be an important part as we hope this drug sort of rolls out into practice. So here's the major news that's coming. This is a large phase 3 trial, and this is in people with metastatic pancreas cancer who've had one prior line of treatment. It's a phase 3, it was a global study comparing daraxonrasib, this pan-RAS inhibitor, to standard of care chemotherapy choices, all of the things that we were talking about earlier, 1-to-1 randomization, and endpoints being cancer control and overall survival. We just have the top-line data results announced. We'll see all of this in less than 3 weeks at the plenary, the major presentation session at ASCO. And the top-line results were that the trial met all its primary and secondary endpoints. And if you look at the overall survival, and this was the one data point that was disclosed, the median overall survival was 13 months relative to 6.7 months for chemotherapy. So chemotherapy did as chemotherapy was expected to do in this setting, but a doubling of survival and hazard ratios. So in trials in pancreas cancer, we're thrilled if we see a hazard ratio of 0.75, and lower is better. 0.4 is kind of stunning, right? Stunning in this disease. So that gives, again, a sense of what's to come. So that's second line. And we're hopeful, we'll see, but we're hopeful that the data from this study that we know is positive, we have to hear all the details, will lead to a regulatory approval in 2026 in pancreas cancer. And now, as you can imagine, the race are to get these drugs into the first-line setting and into earlier stage disease setting. And we've some hints. These were 2 data sets that were presented at the recent AACR meeting last month. And you can see here that this, again, looks very promising. So looking at daraxonrasib, right, a single-agent targeted therapy, a pill that people take daily, relative to what chemotherapy can do, and looking at daraxonrasib on its own and daraxonrasib combined with gemcitabine and nab-paclitaxel using an every other week schedule, which is something we use a lot in practice to help with tolerability. But those two partner nicely, and again, almost every single patient, right? The waterfall plot is showing a downward trend, and we don't know how this is going to pan out in terms of which might be the best, but this is the study that was activated in the early part of 2026, and this is now looking at first line, so newly diagnosed, untreated metastatic pancreas cancer. Standard of care being gemcitabine, nab-paclitaxel. That's, of course, an acceptable choice as we discussed, but looking at either single-agent daraxonrasib or daraxonrasib plus chemotherapy, and both of those 2 arms will be compared to the standard of care. I'll just make the point here that while we want to genotype everybody in terms of the RAS targeting, this drug is a pan-RAS inhibitor, so whether you have G12D, G12V or R, they're the 3 most common types of RAS mutations that we see in pancreas cancer, are some of the rarer RAS mutations, or maybe even if you don't have a RAS mutation, this may still be highly relevant as a therapy choice in this disease. And we'll have to see, in time how the granularity of each different version of the RAS mutation responds to this medication. But we know in principle that all of the key RAS alleles in pancreas cancer respond well. So there's nothing to take home from this slide except to say that this is just, rapid development. And this is a list of some of the trials that have been announced, and these are phase 3 trials, so potentially practice-changing trials in pancreas cancer. And if we go back a year and a half, it was a low single-digit number. We might have had 1, maybe 2 phase 3 trials in pancreas cancer, and I'm sure I'm missing a couple from the slide that was, put together a few weeks ago. And you can probably see here the stages first line, but also in the adjuvant setting, so post-op, where a RAS therapy is going to fit, looking at it in neoadjuvant setting, and those studies are designed, they're maybe not activated yet, but they're coming, and we think that having this class of therapies in every single setting in pancreas cancer, and probably as a continuum, right? That because this pathway is so switched on, so activated, so integral to the biology and to the adverse profile of pancreas cancer, that we're going to need to continue targeting it throughout the disease spectrum. I mean, we still have a lot to learn on that, but just to give you a flavor of that. So summing up here, changing, right? That's the word. I know this is a disease where it's been overdue for a long period of time, but I think that's the message we want to send to patients, that there are therapies now that can help, and chemotherapy is certainly going to continue to be a part of how we approach this disease. But it's nice to think that we're moving into this era of biomarker, precision medicine, and selected therapies, even though it's a kind of a pan-RAS, so it's selected, but in one sense it's not selected. So standards right now on the front line continue to be 3 or 2 drug combinations for most patients. Some older, frail patients, maybe 1 therapy. We've touched on the rare biomarker subsets. So we're likely to have a new practice-changing standard of care in a second line, hopefully a little bit later this summer, and we'll keep our fingers crossed on that. So that's daraxonrasib, second line, after prior chemotherapy, and we'll all need to learn how to use this drug, how to manage the side effects, how to help and support patients. And as mentioned, now role is to kind of integrate these drugs into every stage in this disease. Time does not permit today, but I'll just mention there are a number of other targeted approaches and immunotherapeutic approaches, vaccines you've heard and read a lot about, perhaps in pancreas cancer, that we'll have to think about how we combine them with RAS inhibitor therapy. So thank you. I'll stop there on this, and I'll ask our panel. So Caroline, you're up. Please tell us how you approach genetic testing, particularly somatic genetic testing in the clinic.
So we test all of our metastatic patients.
Yeah. So that's the first point, right? Everybody needs to be tested.
Everybody gets tested. So that's how we approach it. A lot of education with patients about why this is important. Didn't used to be that important because we had no drugs, but now we do, thank God. So everybody gets tested.
And Philip, how do we do the testing? What are the platforms that we use? Tumor, blood?
So I use, when I have a new patient, like I had a new patient yesterday, part of my workup, CBC, CMP, all that, tumor markers, part of it will be doing a tissue NGS. Now the tissue NGS, I send it outside. Sometimes I can do it within the hospital. And then I also do liquid biopsy. And the reason, and I do the germline testing, but let me focus on the liquid biopsy. Why do I do it? I do the liquid biopsy because from experience, maybe 20% of the patients or so who have their tumor sampled, they may not have enough cells from it. Like if you think of how we do the sampling, we do an endoscopic ultrasound, and the tissue might not be enough. So therefore I do both. I do the liquid biopsy and I do the tissue, and I do it in every single patient. So I do the 3 in every patient, germline, liquid biopsy, and tissue biopsy.
So maybe a couple of things just for our audience in terms of liquid biopsies. We use them a lot, and increasingly it can be hard to detect RAS in pancreas cancer. We have the issue of tissue challenges. There's very few epithelial cells and all this kind of stromal mass that makes up pancreas cancer. We can do multiple biopsies and we can be unlucky. A lot of times we'll get back a liquid biopsy and we don't see a RAS mutation. Just to make a point, that doesn't mean there isn't a RAS mutation. It's possibly a detection or a shedding issue or a disease volume issue. And one of the messages that we want to, again, emphasize is that we need to keep testing and perhaps consider a biopsy. It was heresy in the past to think about doing a second biopsy in pancreas cancer, but now it's kind of an everyday thing. Mm-hmm.
Yeah, I would comment on that. I had a patient comes to mind that initially diagnosed as locally advanced disease. We just had an FNA from a pancreas mass, insufficient tissue for testing. We did a liquid biopsy. Again, didn't really show anything significant. Then when he did develop metastatic disease, we talked to him about obtaining a liver biopsy that showed that he had a POL-E mutation and his tumor mutation burden was like over 100. So he went on to then receive immunotherapy and ended up living like another 3 years. So again, just kind of stressing that importance of, we might need more. I know this is an invasive procedure, but this may actually help us kind of as far as helping pick your treatment.
Very good. Very good.
Yeah, so this field is, it is complex in terms of biomarkers, and it is changing in pancreas cancer. But if we don't look, we won't find, right? So just at the time of diagnosis, and typically this has been done in later stage disease when we're kind of more looking for clinical trials. But now we need this information up front, and for even individuals with localized disease, we want to do this testing: germline, tumor-based, and potentially liquid biopsies. So what's your sense, Amanda? Do you think we're there in terms of RAS targeting? Do you see it coming based on the data that you've heard?
Oh, yes. And now, right, unfortunately, we didn't have any of the trials at our institution, but I am fielding questions left and right from patients as far as when can I get daraxonrasib? And now the expanded access program, so working to try to get it to more patients.
And so with that, we'll go to a really important part of this, is how we use these drugs in the clinic. And again, I'll ask Caroline to walk us through this.
Great. This is such an exciting time in pancreas cancer, the advent of these drugs. And I want my portion of this talk to feel practical and useful, and that you come away feeling like you know how to manage patients on this drug, because you will. And not just in pancreas cancer, it will be in other diseases as well. So again, we talked about this, KRAS, it's the holy grail. It is expressed in over 90% of our pancreatic cancer patients. It had been traditionally considered undruggable, and no longer is the case. So let me start with a patient case study. This was a young guy. He's 48 years old, presented in the traditional way. He was treated on our protocol, which was FOLFIRINOX plus RMC-6236, which is also daraxonrasib. He started that treatment in February of 2025. He went on to receive 11 cycles. I'm going to go cut right to the chase. This gentleman had a tremendous response to therapy, where by RECIST, he had minus 83.2% compared to his baseline. Liver metastases shrunk considerably. He did experience various holds and adjustments for rash, mucositis, stomatitis, and thrombocytopenia. And as of this past March, did have a CAT scan that showed progressive disease. But that's 13 months on treatment. 13 months. So let's talk about the KRAS inhibitor, daraxonrasib. So this is an investigational oral agent, which can portend some convenience for patients. It is not yet FDA approved, but it is in phase 3 trials, and it is showing significant survival benefit, which is just incredible. In May, just recently, weeks ago, Revolution Medicine has now opened and expanded access to the drug. So that means that any patient with looking for second-line therapy in metastatic pancreas cancer can go on to get access to this drug. This is going to be big. So the safety profile, it differs from chemo. There's less myelosuppression, not the alopecia, but there are some notable differences in terms of dermatologic and GI toxicity. So let's go through those. The most common are rash. Over 90% of patients get some form of rash. There is diarrhea, which can be considerable and needs aggressive management. Some nausea, vomiting, certainly stomatitis. Other adverse events we see are typically fatigue, taste changes, and elevated liver enzymes. Most of the AEs are grade 1 to 2, and discontinuations, so stopping the drug because of these adverse events, is extremely low. So let's dial in. I know these are scary slides, but I want to give you a real sense that this is not uncommon to see as a rash effect, but these are rashes that can be treated. So it can be mild, you can see on the left, like a drug rash, pinpoint erythema, to real progression to acneiform with eschar, The patient on the your far right he's a public figure, so I felt comfortable showing his whole face, but just to demonstrate the diffuseness of that rash. So let's talk about how you grade these rashes. Acneiform skin rash, it is graded on BSA, body surface area, but you really have to take into account when you're grading or thinking about the rash, the discomfort associated with the rash in terms of considering holds or dose adjustments. So how do we manage this rash? Well, we prophylax with antibiotics as a starter. We start our patients on doxycycline or minocycline prior to their first dose of DARA, and then we continue it for at least 8 weeks. And if at 8 weeks patients don't have rash or it's well managed, they can stop the antibiotics. We employ topical steroids, topical antibiotics as well. Typically, they're not enough to really move the needle, so we often use the topical steroids, the hydrocortisone, clobetasol, triamcinolone, and sometimes oral steroids to make the rash more tolerable. Of course, it's very important to maintain hydration in the skin, so that's perfume-free moisturizers, creams, and lotion. You have to teach your patients about the importance of sun protection. Sun makes it worse, so they need to wear a hat. Sun avoidance is really the key, but if they're in the sun, they need high SPF sunscreen. Again, if patients are having significant rash, like the pictures I showed you, they often need dose holds. And I consult my dermatology colleagues because there are a lot of agents out there that can also be added to the regimen to make the rash more tolerable. And again, we want to help patients stay on the drug. So rash management is really important. Mucositis, it's pretty standard. Baking soda and water, salt water rinses. We love the magic mouthwash, diphenhydramine. This is lidocaine and Maalox compounded, but we've had great success using dexamethasone oral solution, swish and spit. Does a lot to deal with the stomatitis, the inflammatory changes in the mouth. Diarrhea, again, we've talked a lot about this. It's real, it's bothersome, aggressive, early management. And if after stage 1 of loperamide, stage 2 of diphenhexylate atropine not working, those patients need evaluation. And that's if you can't manage it at home, they have to come in. Nausea, again, when we gave daraxonrasib, it was in combination with chemotherapy. So this is our standard regimen of how we manage nausea with the standard 5-HT3 drugs, using dexamethasone as a taper for the first 5 days. And then we use olanzapine at night. It tends to really help people with sort of extended nausea. And after day 5, just the PRN, prochlorperazine, ondansetron, and again, continuing the olanzapine. So in conclusion, what I want to leave you with is that this drug is generally well tolerated with manageable side effects. As monotherapy, when it was given as monotherapy, the biggest side effects that were experienced were rash, diarrhea, and stomatitis. So if you aggressively manage that for patients, it will make the drug tolerable. It was rare for any of the patients in the trials to have to stop the drug because of these side effects. In fact, their discontinuation rate was less than 3%. However, managing the toxicities with dose holds or dose adjustments was common. It was about 60 to 70% of patients needed those adjustments, but the dose intensity remained favorable, between 84 to 89%. You should know there were no fatal treatment-related adverse events on any of the trials at the 300 milligram dose. And when it was combined with chemotherapy, they didn't see any additional new safety signals with those regimens. So I hope this gave you some practical information and a little bit of comfort about how to manage these side effects. This drug is going to be big, and drugs just like it with very similar side effects profile.
Yeah, thank you very much. That was super, and we're all going to need to kind of learn as this hopefully moves into practice relatively soon. And I think it's fair to say the rash has gotten people a little frightened, but I think there is a lot we can do, and the paradigms for approaching this in the clinic will evolve. And just keeping that in mind. And dermatologists have become our best friends.
And I would make one other comment that though the rash is quite unsightly, patients are very motivated when they see responses. And so, again, the impetus is on us to aggressively manage so that it's comfortable, but you'll be amazed at how much patients are willing to accept in terms of that side effect for such great response.
Terrific. Well, thank you. We're going to, for the last section, go to a slightly different topic. It's also a new therapy that's being integrated into practice, and we're going to ask our experts here what this is and how we use it and who's the right patient. So, Philip, all yours.
Thank you. This part of the final part of the talk will be on patients who have what we call locally advanced unresectable disease. You saw when Caroline went into the separation of the stages, I can tell you that a third of the patients we see have locally advanced unresectable disease. By definition, we can't resect them. Even if you give them chemotherapy, only maybe 5% of the patients or 10% maximum will end up with some kind of resection. So the focus is on those patients. Now, if you look at how it looks like, you don't have to be a radiologist to see that ugly-looking mass sitting there, which is surrounding the vessels. And what happens is that it really puts pressure locally to give pain and more pain, back pain, but also puts pressure on the blood vessels. And most importantly, also, it can produce the obstruction in the bile duct and obstructive jaundice that you heard patients can come with. So certainly a very troublesome type of presence of the cancer. You can't resect it. Therefore, you're going to treat it like you're treating advanced disease, metastatic disease, and we give chemotherapy. So they're unlikely to undergo resection, and the local effects are the things that are really going to be affecting the patient's life, in addition to the potential spread to other places. So chemotherapy has been the mainstay of the treatment. Radiation treatment may help with the pain, but it doesn't prolong their survival. So Tumor Treating Fields is a non-invasive way of providing treatment. It's already approved for some other cancers like GBM. And the way it is that the patient wears something around their at the site where you're going to treat the tumor here. And you can see where the applications are based on this picture. But what is it and what does it do? It's non-invasive, which is a good thing, but what does it do? It really generates electricity, kind of disruption that goes into the tumor. It really affects the viability of the cancer cells, and also it can arrest their proliferation, division, and reducing the size of the tumor, hopefully. That was the idea, which really led to a number of studies, but this is the pivotal or the main trial that got it FDA approved. It was in over 500 patients, and patients received chemotherapy. Everyone got chemotherapy, but half of the patients ended up getting the TTF fields on top of the chemotherapy, and the primary endpoint was overall survival. So this is very important to keep in mind. The primary endpoint was overall survival. And the patients who went on it were unresectable pancreatic cancer, locally advanced, favorable performance status, also included 2, which usually is excluded from clinical trials, and patients who could get the treatment in terms of the chemo, or they are willing to have the device put on them. And they have to have the device there for over 10, 14 hours a day. And they can go anywhere with it. It's not like they have to sit next to the machine. It's a portable machine. So what is the outcome of the study? The median overall survival was certainly improved. It was statistically significant, and that was the reason why this study was, when presented to the FDA, the device was approved. The median pain-free survival was also improved, and it was a significant improvement from 9.1 months to 15.2 months. So basically, this parameter is telling you that it had a positive effect on controlling the pain or reducing the worsening of the pain, if you want to put it that way. And also it reduced the time it takes for other sites of metastases to happen. But really the most important thing, which I want to highlight here because of the discussions we had earlier today about palliative care and supporting patients, is that this treatment helped in controlling the symptoms of the patients, and here we're talking about pain. What are the side effects? As you would expect, the side effects will be more related to skin side effects, and patients had dermatitis, rash, pruritus, itching, maculopapular rash, erythema. It only affected less than 10% of the patients to the point that it had to be discontinued. But the discontinuation was not only because of the side effects of the skin. There will be other reasons why patients may elect to discontinue the treatment. But overall, less than 10% had to discontinue the treatment. So the FDA, as I mentioned, approved the treatment, the Tumor Treating Fields, in February of this year, and this is the statement, and you will recognize this treatment as Optune Pax, and it's a portable, non-invasive device, as I showed you where it put, and it stays there for over 10-14 hours, and really it doesn't cause or add side effects except for the skin rash or the skin toxicity that I mentioned to you. And with that, I will go to the next slide.
So, Philip, what do you think is the most compelling part of the story here? And what's your take on sort of patients' acceptance of wearing a device?
So what would be challenging, or?
Pluses and minuses.
Yeah, the plus. So the plus of the using it is what you saw from the results. It prolongs survival. It helps to control the pain, and also it lengthens the time until we see like metastases, for example, in the liver. Remember, this is locally advanced. This is not metastatic to other places, so it can metastasize with time, but it's taking it longer for it to metastasize. So that's the only downside I see. Because the skin toxicity can be managed, but the major downside is patients agreeing to wearing the device for over a prolonged time. Now, is the time that was used in the clinical trial or mandated in the clinical trial, is that really the best time? Can it be used shorter? No one knows. No one has tested it at a shorter period of time. But that's the only thing that I think will be challenging to patients is to, and the other one will be, we use also a lot of FOLFIRINOX or NALIRIFOX in treating locally advanced, and this study was done with gemcitabine nab-paclitaxel. Does the benefit extend to those? Again, we don't know. Thank you. And Caroline, which patients do you use this in?
So we don't use this at my institution, so I apologize, can't really comment, but I think.
Yeah. I've had, the one patient that I did have on trial, he was actually, it was a resectable diseased trial. But overall, he actually tolerated the device just fine. He actually had a harder problem with chemotherapy, more so than anything, as far as blood counts and fatigue.
Yeah.
But I'm happy to kind of get into the practical considerations that we have to deal with when using this device.
Yeah, absolutely. I think locally advanced, right? People with pain where the data is compelling, but please tell us how to use this, what we should be looking for, and how to manage it.
So, as Dr. Philip mentioned, this is an electrical field generator. So, what it comes with is the actual device, and then these transducer arrays. There's 4 of them, one that goes on the front and back, and then on the 2 sides. Those have to be changed every 3 to 4 days. And then they get a portable power supply that they can plug into the wall, as well as 4 batteries, rechargeable batteries, and then a charger for those. So kind of logistical considerations, it needs to be worn at least 12 hours a day. It comes with a provided bag that's designed to allow for proper airflow, so it's important to educate patients, don't change the bag. If they're going to be away from home for more than an hour, they should carry an extra battery with them. It's not necessarily that it's going to run out, just always be prepared. The device uses 1 battery at a time. They should have 12 of the arrays on hand at all times. And they come in 2 different sizes, a small and then a regular size, just to accommodate different body sizes. They will activate metal detectors, so if like they're traveling in an airport, it's a consideration. The arrays should not get wet. We'll kind of talk about as far as, taking them on and off. So I personally think that would be a big challenge, that I would have to sponge bathe every 2 days because I can't get this wet. And they should not be used in patients with electrical implants or really strong sensitivities to gels like used on EKG stickers or TENS units, or pregnant patients, but that's just an aside. So as we've mentioned, the biggest kind of side effect is going to be the skin toxicity. When their patients are placing the arrays, wash your hands thoroughly. If it's, a man with a hairy abdomen, just to shave with a clean electric shaver. Wash the skin with a mild fragrance-free soap. You're going to want to apply topical skin products, so moisturizing cream, probably best to go ahead with a skin barrier film, corticosteroid or antibiotic creams. Leave those on for about 20 minutes before actually placing the arrays. And then they are educated on where the placement should be, and they may need help with the placement of the array on the back. And then to take them off, this is when they get their shower, so they can go in the shower to completely saturate them, and then they need to apply even pressure and tension to slowly pull them away to avoid excess, irritation to the skin. And then when they take them off, that's when they really need to evaluate for those signs and symptoms of skin breakdown. So kind of the management and mitigation strategies of how we manage these rashes from these arrays. As Dr. Phillip mentioned, majority of patients did have mild to moderate skin irritation. Less than 10% required a break from treatment because of the skin toxicity. So number one is prevention, making sure you're using mild fragrance-free soaps, patting the skin dry, avoiding products that contain alcohol, fragrance, solvents, moisturize daily, wear loose-fitting clothing, sun protection, and then they can shift the arrays with each place or each change by about 2 centimeters to avoid having that same repeated skin exposure. And then, when we're seeing these patients with the tumor treating fields, it's usually good to consider seeing them pretty frequently in the first 4 weeks of treatment to kind of monitor for skin toxicity. I'll often say, why don't you take pictures at the time of array placement so we can kind of monitor. So it might be a good idea to consider prescribing kind of those skin barrier films, low potency steroids from the get-go. And then if they do develop skin toxicity, if it's very mild or asymptomatic, again, just kind of these preventative measures of moisturizing creams, topical steroids, continue treatment without interruption. So grade 2, if they're symptomatic, there's localized erosions or pruritus that's interfering with ADLs, you might want to up your steroid game and consider triamcinolone, consider adding topical antibiotics, antihistamines, and then continue treatment. If they're really symptomatic and, it's an intolerable kind of grade 2 toxicity, you could consider a 2 to 7 day break from treatment. Grade 3, so we've got skin breakdown, bleeding, widespread erosions. This is when you definitely want to get dermatology on board, add wound care specialists, may need topical or systemic antibiotics, steroids, and would want to interrupt treatment and then resume once it's resolved to grade 1 or less. Grade 4, full thickness skin breakdown, infection, necrosis. You're permanently going to discontinue the treatment.
Thankfully, both of those are rare.
Yeah.
Just in case we're all getting worried here.
Yeah.
And maybe we'll go to your case just for the one last thing. So, just in terms of the practical setup.
Yeah. So, my patient, on this trial, he had to wear it for 16 hours a day, which I felt like was a long time. And then again, he really only had very mild issues, and we were able to control it with just using topical steroid, hydrocortisone, and the skin barrier wipes, and then kind of shifting those arrays. Like I said, for him, it was actually more so the side effects from, chemotherapy that caused him to actually stop treatment.
Yeah, I think fair to say it's a pretty well-tolerated thing, just maybe a little bit of a nuisance, but we encourage people to try to keep it on as long as they can. Skin toxicity is relatively mild. Well, with that, I'm going to draw the program to a close and just going to thank our terrific faculty and you all for coming, and our colleagues who have joined us online. So enjoy the rest of the meeting and have a good day. Thank you.
Thank you.